Yes, a blood pressure of 12/8 or 120/70 is no longer considered normal. Wow, Eder, but does that mean the pharmaceutical industry is going to make a killing now? Well, that's a wrong interpretation. That's why you're here, so you can get information interpreted by me, so you don't get fooled or have nonsense in your head, okay? So I'm going to talk here about what was discussed just now, the week before last, right? The Brazilian Society of Cardiology discussed and released the new classification of arterial hypertension in Brazil. Understand this. In Brazil, in the past, last year, information came out from the European Society. People said a lot of things. I said, guys, that's the profile of European patients. Now, yes, the Brazilian Society has released the guideline that will be followed in the coming years, and it has many updates. All right, if you don't want to miss out on topics like this that will keep you updated, make sure to subscribe, like, and share so you can stay up to date, learn, and not mess up in your daily routine. All right, let's go. Guys, so the first step, what happened, right? There was the 80th Brazilian Congress of Cardiology in São Paulo, and the changes in blood pressure have already been defined. So let's make a few things clear here. I'm not going to talk about the practical part, which also had a few small changes. Today, I'm going to talk about the classification. What has changed, but let's pay attention before I talk about the screen, okay? Where are the little tables? What happens? Why isn't 120/82/8 considered normal anymore, Professor? The human body isn't the same, the patient isn't the same, but you're in 2025. You're in a post-pandemic year. You're in a time when society has changed a lot, including eating habits. So, it's very important for all of us to understand that this doesn't come from the pharmaceutical industry, especially since medicine is far from that. From here on, we need to understand what it means for someone to be pre-hypertensive. This is the understanding we need before working with the numbers. And another thing, numbers need to be interpreted. So, the first step is this. Normal systolic blood pressure has to be less than 100% and diastolic pressure less than 80. So 119/79 would be the perfect normal, and pre-hypertension is from 120 to 139 systolic and from 80 to 89 diastolic. But what is pre-hypertension? Pre-hypertension is when a person doesn't have hypertension. Maybe you don't have hypertension and your blood pressure is 120/80. You don't have the disease, but you are pre-hypertensive. What does that mean? It means that if you don't follow some recommendations, you could become hypertensive. With values starting from a systolic blood pressure greater than 140 and diastolic greater than 90, that hasn't changed, it's the same thing. So 140/90. Diagnosed in the office, hypertension will prevail. So this pre-hypertension that people keep talking about without having the information means that the person is at risk of developing the disease now in their body because they are in a risk zone. So the value from 120 to 139 systolic is a risk zone. You don't have the disease, but you can develop it, understand? So 12/8, 120/80 is pre-hypertensive. It doesn't mean the person has to take medication. No, they're just at risk. If we take a break here now and go there, in the Brazilian Diabetes Society, there isn't a person classified as pre-diabetic. They're diabetic. No, they're not diabetic. They haven't been diagnosed. They're at risk of becoming diabetic, but they need to do some things. It may be that in some cases they even take medication, period. Here we're back to hypertension. So, with hypertension, guys, before people get worried thinking they'll have to take medication, no, hypertension. It's just a risk of developing the disease. You won't have to take medication unless your case is different. But it's just to understand that this classification was just a warning for the population, right? No? All right, so moving on here. I'm not going to talk about stages 1, 2, and 3 because basically nothing has changed at all, only the terminology has changed. So before we had normal blood pressure, now we don't have that anymore. It's either normal or pre-hypertension, and then the stages of hypertension. Now here's what I need to work on here so we can understand it more easily. In the office then, you go to a doctor's office, you go to a family health clinic. There in a doctor's office, you will be seen by a doctor. The blood pressure measured in the office, if the systolic pressure is higher than 140 and the diastolic is higher than 90, this already defines arterial hypertension right there in the office. Now, there is an ambulatory blood pressure monitoring, which is the measurement of blood pressure over a period of 24 hours. It's the ambulatory blood pressure monitoring. If it is higher than 130 and higher than 80, it is already classified as hypertension, right? And then there's the MRPA, which is the same thing as the ambulatory blood pressure monitoring, but instead of lasting 24 hours, it goes on for a few days. So, it depends on the protocol that will be applied for the MRPA, which is the home blood pressure monitoring. Okay, in the same way, MRPA of 130 over 80. Now, what we need to take into consideration here is white coat hypertension and masked hypertension. Guys, you might be from the healthcare field, but there are people who, just by arriving in an environment with doctors, nurses, people in lab coats, she already has a certain change, so she also takes that into account. It's not just recent, she's been considering this for a while. So, we have hypertension that a person might have, but it's not real. What do I mean by not real? If the blood pressure is the person's own, it means that when the person is in that environment, they already have a slight tachycardia, which slightly increases their blood pressure. So that value is a false positive, meaning that value isn't real for diagnosing the disease. So I can't take the reference value from the doctor's office and apply it to white coat syndrome. So what did you put here for white coat syndrome? It's 140 over 90 or higher, but normal is less than 130 over 80 with home blood pressure monitoring. So I'll only consider white coat syndrome. If, for example, in the doctor's office it was 140 over 90, but on the ambulatory monitoring it was less than 130 over 80, the numbers don't match. A value that's checked over 24 hours in the absence of healthcare professionals, but in the presence of the other. So I have a discrepancy, man, it's not right, so this needs to be analyzed. A prevalence of 7% to 15% is common in patients with stage 1. So what is he going to consider? He will consider a change in percentage. For example, we notice that this person, every time they're in a place with healthcare professionals, they have a change in blood pressure. All right, I got it. So we're going to consider up to a 15% change, okay, to make the diagnosis there. The prevalence of masked hypertension goes up to 22%. So, white coat hypertension and masked hypertension, what will they have? A change that is an increase of 15% in white coat hypertension and 22% in masked hypertension. That's what's stated here by the society, okay? Risk factors such as diabetes and obesity, which can lead an individual to become hypertensive, up to 62%. That's why blood pressure can be checked in people over 18 years old, and you can already start thinking about the diagnosis. Look how interesting that is. We are in 2025 if we look at several other Brazilian cardiology guidelines. When it comes to hypertension, we used to have a different audience, but now we have people from 18 years old where we can already do screening and diagnose blood pressure, okay? I found this very interesting because we're already seeing very young people being diagnosed with hypertension here, especially those who are obese and mainly those who are sedentary. And that's really important, okay? One thing that stood out regarding blood pressure is the stratification of cardiovascular risk. And then I have cardiovascular risk, I have renal risk, I have the possibility of target organ damage. So each of these needs to be discussed in detail. I won't discuss that now due to time constraints, so we'll need to analyze these factors. And there are some very important changes here, non-pharmacological measures, right? In other words, we don't need to talk about medication, we need to understand what society wants. It wants to show that some measures that don't involve medication are interesting for controlling, regulating, or even making the person stop taking medication. And here it is, look, body mass index between and 24.9 waist circumference, diet, physical exercise, so all of that. Look, these are non-pharmacological measures, so people who are stratified, at risk, or have the possibility of developing the disease, in other words, someone who is pre-hypertensive, can take non-medication measures. Medication is only for cases where we have a patient diagnosed with hypertension higher than 140 systolic and higher than 90 diastolic. Okay? So, in summary, that's it. Another thing is the phenotypes, right? For people who may have hypertension, analyzing the phenotypes is important. Here it also talks about the phenotypes and the risk factors. And there's the prevent risk score, more than 20% in 10 years. This prevent score, I need to make a video just about prevent, okay? Just so we understand, so we can wrap up here. Non-pharmacological measures for pre-hypertensive patients, that is, with systolic between 120 and 139 and diastolic between 80 and 89. Pharmacological measures are for those with systolic above 140 and diastolic above 90. In other words, nothing has changed from before. So the pharmaceutical industry didn't have any influence to change the terminology or the information because the medication is recommended at the same value as in the 2020 guidelines and previous guidelines. In other words, no one is going to take medication early like, oh, I'm pre-hypertensive, I'll take medication. No, that's not the recommendation. Now, except for someone who has a particular condition, the cardiologist will recommend the medication for weight loss. That's a different situation to improve dietary performance, in other words, with non-medication measures. That's pretty interesting, okay? And a person who has a blood pressure of 130 to 139, 80 to 89, he is in the pre-hypertensive range, but if he has any of the risk factors I've already mentioned, like cardiovascular, kidney, target organ damage, and so on, in this case, medication is recommended. Not for blood pressure, but to reduce the possibility of risks. He was stratified, and he has the risks. Okay, the guy is 30 years old and he's obese, grade 2 obesity. His blood pressure is 135 over 85. Man, he's not diagnosed as hypertensive, he's considered pre-hypertensive. Okay, he needs to lose weight, maybe he'll need medication to help him lose weight. So, what we need to take into consideration is that a person who is diagnosed as hypertensive will take medication. Pre-hypertensive individuals take medication only if they have risk factors, which must be evaluated along with the appropriate medications. Not necessarily what is for blood pressure, not necessarily because what raises their blood pressure, it doesn't help. This is a mask shop, right? I prescribe medication to lower their blood pressure, but the issue remains. The cause could be obesity or something else. If we don't address the cause of high blood pressure, medication just controls it, which doesn't make much sense. So interpret, analyze, because this is extremely important. All right, so basically that's it. If anything comes up, we'll do another session later. I'll make a session just about medications, okay? Then we'll work on something much more interesting, all right?